So I would thank the chairpersons and organizers for the opportunity. So we had a very interesting discussion, smoking and immunotherapy. And this is a simpler discussion whether autoimmune diseases, if there is a history of autoimmune disease, is there a risk with giving immunotherapy? So this is the paper, whether pre-existing autoimmune disease is associated with higher mortality with immunotherapy. So well, we know that immunotherapy has been approved in more than 19 malignancies. And if you look into the clinical trials, they have excluded patients who have history of autoimmune disease because of concerns of exacerbating underlying autoimmune disease, increased treatment-related adverse events, and achieving poorer response. So because of all this, if there is a history of autoimmune disease, they have excluded. So this study investigates the impact of baseline autoimmune disease on survival among cancer patients. So this is a retrospective analysis from the TriNetX Diamond network, and they use the log rank test, and what you need to remember is the hazard ratios were calculated with the BH correction for multiple other comparisons. So well, the immune checkpoint inhibitor included were PD-1, Nivo, Pembro and Semiplimab, and PD-L1, Durva, Avelumab and Atezolizumab. And they used 4 common sites: lung and bronchus, digestive organs, melanoma and urinary tract. So these are the baseline characteristics. You can see exactly a well-matched population, including the race, the organs involved, gender, all of them were well-matched. And then, so you look into the number, it's 17,000 odd patients. It's a well-conducted retrospective study with the history of autoimmune disease, and the median duration of follow-up was 1.76 years and 1.8 years in study and control population. So well, the conclusion is patients who have a history of autoimmune disease did not have a statistically significant higher mortality if you treat with immunotherapy. Therefore, if there is a history of autoimmune disease, unless the patient has an ongoing steroids and has active autoimmune phenomena, so giving immunotherapy will not affect or does not have any implication on mortality. So well, if you go into finer details, if a patient has a history of Hashimoto's or vitiligo, that patient tends to do better than those who did not have autoimmune disease. Similarly, other autoimmune diseases like celiac disease, lichen planus, alopecia areata also tend to do better, but was not statistically significant. However, type 1 diabetes did poor if there was a history, if you use IO in these patients. So well, just to quickly summarize in a simple way, the duration of immunotherapy did not vary. You know, if there was an autoimmune disease, this did not result in early discontinuation, and there was no increase in mortality. So if you use PD-L1 monotherapy, no difference in mortality. If you use a combination of PD-1 and CTLA-4, again there is no difference. However, PD-1 monotherapy, there was a slightly increased risk of mortality. And this slightly increased risk of mortality is more in patients who had rheumatoid arthritis, IBD, type 1 diabetes and mucositis. So in contrast to thinking of Nivo-EP causes more autoimmune phenomena, so Nivo-EP sort of CTLA and PD-1 was not associated with higher mortality. So well, the hypothesis is, so the concluding message is, if you have a history of autoimmune disease, IO can be safely given and there is no increase in mortality. However, some subsets of autoimmune diseases have a better outcome in whom steroids are not required. Whereas if you have an autoimmune disease where steroids are required, in those patients there is a slightly increased mortality. However, this particular retrospective study did not address the issue of whether steroid use reduced mortality. So, if you have a history of autoimmune disease, you can safely give immunotherapy and it has no influence on mortality. So, I would thank all of you for patient listening.